Diagnosis and management of cerebrospinal fluid rhinorrhea. There is about 90 to 150 cc's of CSF in the subarachnoid space and ventricles. For cerebrospinal fluid rhinorrhea, there must be a defect in the dura, an osseous defect, and a mucosal defect in the nose. Common etiologies include iatrogenic during surgery, benign intracranial hypertension, and congenital defects of the skull base. Classic symptoms include clear rhinorrhea that is typically unilateral and highly positional or with exertion or valsalva. Workup includes a complete head neck exam, nasal endoscopy, testing the rhinorrhea for beta-2 transferrin, and high-resolution CT scan of the skull base. This is often diagnostic. The most important principles for repair are to obtain adequate exposure, to expose the site, and remove mucosa around it. The defect can be repaired with rigid materials such as cartilage or bone, which is favored, and artificial dural substitutes. Repair materials have shown no difference in repair success. It is critical to repair the size of the defect and its characteristics with repair technique chosen, as illustrated here. In this first example, there is an iatrogenic CSF leak at the skull base and cribriform secondary to sinus surgery. In another iatrogenic case, there is CSF rhinorrhea from the sphenoid sinus after pituitary surgery. On valsalva, there is CSF rhinorrhea from the site of the hypophyseectomy. Repair is carried out by first exposing the site by removing the mucosa around it to expose the dura. Next, a fat graft is obtained and placed within the defect. Finally, a pedicle nasoseptal flap is placed to cover the defect. Here the pedicle is illustrated. The graft completely covers the defect. The mucosa is fully healed 2 weeks later. In this example, there is a CSF leak in a lateral sphenoid sinus. First, the leak is exposed by a transmaxillary transpterygoid approach to the lateral sphenoid sinus. Here, the pterygopontine fossa is exposed prior to cautery of the internal maxillary artery. The contents of the pterygopontine fossa are displaced inferiorly to expose the lateral sphenoid sinus. The defect is exposed after the posterior wall of the maxillary sinus is removed. The defect was then repaired with a dural substitute with success. This patient presented with spontaneous CSF rhinorrhea secondary to benign intracranial hypertension. On exploration of the cribriform, there is a meningoencephalocele protruding through the cribriform with CSF rhinorrhea. CSF leak is indicated here. It is reduced with bipolar diathermy after adequate exposure. It is then repaired with an onlay of a dural matrix substitute. We are careful to achieve adequate exposure by removing the mucosa around the onlay graft. We ensure that the onlay graft is not on any mucosa. Here, the mucosa is being removed from underneath the onlay graft. The graft is then secured in place with tissue glue and gel foam. Multiple studies have shown excellent results from endoscopic repair of CSF rhinorrhea. Overall, about a 92% success rate, with a 94% success rate with pedicled flaps. In conclusion, we review the diagnosis and management of CSF rhinorrhea.